A big hello to everyone joining us from different parts of the world. I know it's difficult being at home, being forced to stay away from work, but this too shall pass. So today we are here for yet another topic to be discussed, something which is not given that much of importance which it deserves, because shade taking is actually the interface where the restoration either can exceed the expectations or go far below what was promised to the patient. So, my dear friends, here we are today talking about shade taking protocols in indirect restorations. I have kept the presentation away from the general review discussions of different steps for taking shades. I have made sure I am not keeping the history of shade taking into the presentation. I am keeping it purely from the clinical content. There will be a lot of take-home messages, things which I do in my practice, which has given me decent results, which when implemented by the people I train, I educate, also is beneficial. So I'm trying to make sure the presentation is focused purely from the clinical perspective with a lot of take-home messages. The goal, be it a restoring clinician, be it a prosthodontist, be it anybody who calls themselves as a smile designer or working in the anterior aesthetic zone, is to achieve a seamless transition of what is being replaced to what is existing. The restorations have to be lifelike or induce life into a smile, because ultimately the smile has to blend with the face. Tomorrow, when you get back to practice, these words will play a resonating effect in your ears, because you will realize that yes, I made that difference, because the restoration is something which has blended so well in the mouth that I have to go back and check which one is natural and which one is artificial. So God had created, you have recreated. So the goal of a clinician and a technician is the same: patient satisfaction. And for that patient satisfaction to come, we need to work together as a team. If we have to think from a technician's point of view, whether he's going to stain and polish your restoration, whether he's going to layer the restoration, or he's going to have a full contour with a cutback to finally give you the characterizations you are looking for, his job is to deliver beyond your expectations. On the other hand, if he's doing a CAD designing, the basic goal still remains the same. He wants to deliver restorations which are lifelike. On the other hand, we as a clinician, whether we are going the digital way or the analog way, whether we are doing tooth-supported restorations or we are doing implant-supported restorations, the goal is the same. We need to give ample amount of stuff, substance to our technicians so that they can collaborate with you to deliver the results which the patient anticipated before coming to you and has a sense of satisfaction once the restorations are looted. And when the bridge between the technician and the clinician is merged to give restorations which look better than what the original teeth were, it is something wherein content starts to come in. And here, if I tell you that in this case, there are only two veneers present in tooth number 6 and 7, or 1, 3 and 1, 2, you will realize that the amount of work which has gone in to make sure it has blend with the entire outline form of the existing teeth, there has been an excellent collaboration between the technician and the clinician. So was it luck by chance? There is a lot of work, and the very critical step, whether we go the digital way or the analog way, is shade taking. And this part, if not paid attention to, can be detrimental to giving us a good result. What is this? Well, in simple words, these are patient casts. Let's reframe that. What is this? Okay, we can better the answer. This on the left is a stone model from a type 4 dental stone or a die stone, which was poured from an analog impression. On the other hand, on the right hand side of your screen, you see a 3D printed model, which is printed from the STL file, which was given to the technician after the teeth was scanned. What do these represent? These represent the patient. Now, we as clinicians anticipate our technicians to give us a wow effect. With what? With these scars. But, my dear friends, let's analyze. These scars are everything the technician can ever imagine about the patient, because these scars are everything to do with the gender of the patient, the age of the patient, anything specific we want to desire. We have absolutely no information which was passed on to the technician. So looking at these mere models, can the technician know whether the patient is a 20-year-old, a 30-year-old, or a 50-year-old? No. Whether the patient is a male or a female? No. Whether the patient has any hypoplastic tissues? No. Whether there are any enamel hypoplasia spots? No. Whether there are any crack lines, some amount of textures which need to be incorporated? No. And what do we expect? The work which is going to come from our lab is going to really blow the patient away. But have we given sufficient information to the technician for him to visualize the end result before he actualizes the work? That is where the drawback comes in. So we as clinicians need to supplement our technicians with all the information. Now, this information can be photographs, can be in the form of drawings, customizing what exactly we want on a specific area which he has to replicate on his restorations. Everything needs to come from us, because the technician rarely gets to see the patient. He rarely gets to see your vision of what you envision the final result to be. So you have to be the vision of the technician and provide him everything which will help him deliver the restoration which will reach your expectations. So that is what is the characterization which will come in for him to give him a restoration, which when placed in the patient mouth gives a wow effect. So the shade taking protocols will be dealt with under the following heads: shade of the proposed final restoration, shade of the prepared tooth, shade of the block, and shade of the final luting cement. Before we start, let's bust some myths. Things which have been told to us, things which we have imbibed knowingly, unknowingly, accidentally. It has become like a mechanism. It's become like a reflex. Perfectly fine. But until we realize that we can see things in a different perspective, we can do things better, we can deliver results in a more predictable way, we should always be open to realize that yes, there is a better way forward. So what are the myths which we have always carried along with us? Number one, shade needs to be always taken in broad daylight, in natural light, in sunlight. That is something which goes into our system. But my dear friends, out of 24 hours we have in a day, how many hours do we spend in broad daylight? I'm not talking about the lockdown time, because now we better be at home. Stay at home. That's the message. But I'm talking about our regular days when we will be getting back into practice. How many hours in a day do we spend in broad daylight? Be it walking on the streets, be it by the beach, be it in the park, that's broad daylight. How many hours do we spend? Less than 5%, 10% of the time. And we anticipate that the restorations which we fabricate should blend with the existing natural teeth in broad daylight. But on the contrary, the patient, the subject, and including you and me, we have our day spent under different lighting conditions. So what we need to realize is that shade needs to be taken under different lighting conditions, and the restoration has to blend with the natural teeth under different lighting conditions, not just natural light, not just daylight. Number two, we know that the shade tabs which we have are monochromatic. A tooth is polychromatic. And what's the general consensus when we talk about taking a shade? Hypothetically, we look at the patient for 2 to 3 seconds, something which is closely matching, that's the shade tab we pick, and that becomes our shade. And that shade is my HCV, not hepatitis C virus. It is the hue chroma value. So now let me ask you guys, I am anticipating to take the hue chroma value of a polychromatic tooth with a single monochromatic shade tab. Am I not playing with fire? Am I not waiting for a mishap or a disaster in the making? Yes, because that's where the error is going to come in. And that's where I will share my technique, where till now it's been working for me. And I will be more than happy if it works for you. First things first, there's something known as a Vita Classic Shade Guide, which is brilliant as far as teeth whitening is concerned, because the shade tabs need to be rearranged based on value. Now, what is value? It's the intensity of lightness or darkness. So we need to rearrange that based on value. So having your pre and post shade taking or value taking for teeth whitening, this shade tab works really well. That's it. So if you have a Vita Classic, let it be limited or restricted just for shaking the pre and post for teeth whitening cases. Coming to any of our indirect restorations, the least we want is a 3D master shade guide. The least we want. If you can have a linear shade guide, great, because there you have sections made on hue chroma value. But the technique to follow to get the right hue chroma value is what I'm going to be explaining, which is common for the 3D master or for your linear shade guide. And of course, if you have the money to invest in something called a spectrophotometer, your work is done. But I trust my eyes, I trust my skills. So I still go the analog way and not the digital way. That's a rare statement, but yes, in certain areas, I still prefer going the analog way. So what I do is, I make sure that we have the entire frame present, which each of these shade tabs placed in their respective sockets. For those who know the 3D master, great. For those who don't know, I will explain in a very simplified format. Now, Vita talks about taking the value first, then the chroma, and then the hue. But common sense is, if I look at so many shade tabs simultaneously, I might not be able to identify things clearly. Similarly, if I have so many people coming towards me simultaneously, I will not be able to identify everybody with name. So what's the simpler way? Eliminate things which are least conspicuous, focus on the things which are important, and that is where the crux is going to come from. So what I do is, in simplified versions, I divide the entire shade guide into families. So if you see on the screen, there is a 1 family, a 2 family, a 3 family, a 4 family, a 5 family. There's a bleach which is separate, we will not be including here. So there's a family which is present, and within the family, there are sub-family members. So we have the family sailor 2, 3, 4, which will be again subdivided into the M, into the L, into the R, right? Now, what I do is first I will remove all the L's and all the R's. So now I have only the M's, or the father of each family, which is present. Now, this is going to give me the basic color of the tooth, or in simplified version, in which family the hue or the basic color of the tooth belongs to. Where do I look at the basic color of the tooth? Somewhere in the middle third of the tooth. So once I look at the tooth, I keep my shade tab with only the M's. That's where I know whether it belongs to the 1 family, the 2 family, the 3 family, the 4 family, or the 5 family. Once I have assigned the tooth to a family, that is, once I have understood the hue, the next step is I replace the missing N and the R of the same family. Now, if I move left and right from M, I am going to get my chroma. If I move up and down within the family, I get my value. So the saturation is dependent on whether the tooth is more orangish reddish or yellowish brownish. Depending on that, I'm going to be moving left or right. Where do we look at the tooth? Either in the cervical third, which has a dentin predominance, or on the canine, which has a chroma on the higher side compared to the incisors. When I say incisors, I'm talking about central and lateral both. So that is where we look for to get the chroma. Hue, 99.9% of the people will get it right. Chroma, 90% of the people will get it right, because that's what we are used to when we have our traditional way, or the way which we've been using to take the shade. So once we are able to get the hue, the chroma, 35 to 40% of the work is done. Why? Because we need to value the value. If we don't value the value, the restoration will not have the value, which will make it invaluable. So we have to value the value. And how do we do that? First, let's understand the basic properties of light. Now, long ago, once upon a time, when we were studying physics, we were made to understand that when a source of light or incidence of light, when it passes from one medium to the other medium, there is bending of the light which occurs, which is commonly known as refraction, right? That's what we all have learned. That's what we all imbibe. How does that play a role when we are doing value selection for our indirect restorations? The shade tab is in our hands. The tooth is in the mouth. The tooth in the mouth is soaked in saliva. So the shade tab in my hand is in the medium of air, and the shade tab, which is supposed to replicate or find the value of a tooth, which is in the mouth, is in the medium of water. So rephrasing the statement, if a ray of light, or when I am looking at a tooth which is soaked in saliva or water, wouldn't the value which I get be right? Or the value which I get would give me false positive results. So the value needs to be valued. How do we do that? The first thing is we need to make the media the same. So either using our 3-way syringe, we have water on the shade tab and water onto the teeth. So now the media is the same. So there is no refraction which is going to occur. We can also use a bonding agent, completely your choice. Now, there's something known as power of accommodation. So if you tend to look at something which is not looking but becomes gazing or staring, you tend to have things which work into a specific way, which we don't want. So you need to have 3 to 4 seconds of observation and leave. Now, there is a chance that you will be able to identify or shortlist 2 to 3 shade tabs which almost look the value of what the tooth looks like. Perfectly fine. Perfectly fine. Now, we have taken care of getting the media the same. We have taken care to look at it for 2 to 3 seconds. We can repeat the exercise by looking at something which is neutral. Perfectly fine. But now we cannot have 2 values. The value will be always 1. And how do we get that 1 value? We keep the shade tabs where we suspect the value to be in close approximation to the tooth, and we shoot an image with a DSLR camera. Mind you, the image needs to be shot in a monochromatic version, or we need to take a black and white image. And when we blow that up onto the big screen, we get to know what is the value which best reflects on the shade tab, which corresponds to the value of the natural tooth. So that's how we take the hue, chroma, and value. And trust me, this works for me. And the restorations just seamlessly blend into the oral cavity. And when we have things which are not as favorable, as straightforward, where there is an intrinsic discoloration of a tooth, or the prepared tooth structure is a lot darker than the adjacent tooth or an adjacent prep, we need to take the shade of the prepared tooth, or we need to take the stump shade. Because if I am the technician and this is a cast which comes to me, I will never be able to imagine, unless communicated by the clinician, that something which looks the same in diastone is actually having variation in the shade. So we need to take the stump shade. Now, based on what the stump shade is, the technician will be able to identify what he needs to do. If the stump shade is more towards the ND5, ND6, ND7, ND8, ND9, he will be using something which is more opaque as a block for milling or for pressing. And instead of using a cutback or a stain and polish, he will be layering the restoration. So his work is dependent on your information. Didn't I say that earlier? We need to provide all the substance, all the material to our technician to make sure his work is streamlined and the results are a lot more predictable. And we also can have variation, which is present into a tooth. A tooth might be discolored at certain areas or might be discolored more in the cervical third, less in the incisal third. That also needs to be recorded, photographed, and communicated with our technician. The more we communicate, the less of guesswork will happen from the technician. More predictable the results, better the quality of the final delivery. So whatever is the transition which we are looking at, the results seem to just blend in because the teamwork of this interface is working. Now, everybody tells glass ceramics is Emax. Great. But Emax, if you see, also has different translucency in their ingots. Similarly, everything which is milled or a press is not glass ceramic. It can be resin composites, it can be infiltrated ceramics, it can be glass ceramics, it can be oxide ceramics. Material selection is not part of the session today, but we need to know the materials as well. Because if we don't know the materials and we only tell the technician Emax, lithium disilicate, that is where the Pandora box is going to open up, because he will have no clue what is looking for. Whether I need to have a low translucency, a medium translucency, a high translucency, whether it is going to be a high opacity, whether I need to have a low opacity, whether I need to use an Emax Press Multi or Opal. He has no idea. If you have not communicated the thickness of the material you want, which is the preparation depth of what your restoration is, he will not know whether I need to layer, whether I need to have a full contour with a cutback, or I need to have a full contour with just stain and polish. So are you able to understand that if we don't understand, there is a high chances of the technician being either confused, trusting his instinct, or going by his gut feeling. And in any of these scenarios, the final result will not be favorable, because the things which look good on a cast might not look good in a mouth. And what are we looking for? A seamless restoration, a pink and white blend, or a pink and white interface, which makes the work go beyond expectations. So if you focus carefully on the entire Emax family, which I have showed in this slide, we need to identify what needs to be done. So for that, in a nutshell, I'll tell you what these ingots do. If you look at an HT block, now whether it's an Emax Press or an Emax CAD, CAD is a computer aided design. So these will be press ceramics or a pressable ceramics. Those will be milled ceramics. So if we look at HT, high translucency, these are just enamel ingots. So preparation will vary between 0.3 to 0.8 mm. That's it. Anything below 0.3, Emax is not the material of choice. Again, material selection is not part of the topic, but we need to understand there are other glass ceramics also present, because Emax, it doesn't equal glass ceramics only. So we need to identify the material which is used for every case. If we look at the MT, medium translucency, this is a hybrid of dentin and enamel, depending on what the case is. Each of these will be full contour with stain and polish. Similarly, LT, low translucency, is primarily dentin ingot and can have micro layering possible. Micro layering is possible. Now, when we look at Emax Press Multi, these are polychromatic blocks, which will be monolith or a full contour restoration, will have a gradation of different shades of the dentin to the enamel. That's why the block selection is important based on the thickness of your preparation and the translucency of your block, which is inadvertently dependent on getting the value right. If we move, we also have the opacious blocks, which will not work for stain and polish, which will not work for cutbacks. These will have to be layered. So if we have a stump which is on the darker side, we need to have ceramics which are glass ceramics, which will be layered. However, if the discoloration moves more on towards the ND6, ND7, ND8, we have to move from glass ceramics to something which is more opaque or something known as opacious ceramics. That's where we have our oxide ceramics like zirconia and alumina playing a role. Material selection, not part of the topic, but we need to know because we will be the ones who will be telling everything to our technician. Now, another important point is we have taken all the care to get the hue chroma value right of what we propose the final restoration to match. We have got the block shade right. We have also got the final thickness and the translucency, which will help the technician get things ready. But there is also a possibility that if you do not know the shade of your resin cement, the restoration will look different after luting than what it looked before luting. So what is the common thing which everybody does? Use a translucent for everything. There's no one rule for everything. All of us have got central, lateral, canine, premolars and molars in the same order. But do our smiles look the same? No. Do we look the same? No. That's where the customization needs to happen. Similarly, there is going to be a difference in the hue chroma value, difference in the thickness in the preparation. So there is different amount of light which is going to be reflected. If we have minimal preparation, we will be having the underlying tooth reflecting light. However, if the shade of the cement is on the darker or the opacious side, the cement is going to be blocking light and the restoration will look a lot different. So we need to get the shade of our resin cement right as well. How do we do that? What comes to our rescue? We have the try-in pastes. These try-in pastes are water-soluble pastes. That means you can divide the mouth into two halves. One side you can have the value of the cement matching the value of your tooth, and on the other side you can use a translucent. And then take a call which looks more natural or which looks more opacious. And that is where the final restoration shade is going to be selected. Very, very important step. Because after all the hard work, if the restoration is luted with a shade of your resin cement which is not optimal, the hard work will go for a waste. And remember, after luting with resin cement, the only way to take the restorations out is to section them and cut them. So all the minimally invasive steps you would have done till that time You'll go for a toss because there will be inadvertent tooth damage. So it's going to be a real pain. So we need to spend one extra step to get one thing bettered. So to summarize, my dear friends, what are we looking for? We are looking for long-term success. We are looking for predictability, and we are looking for aesthetics and function to go hand in hand. What are the prerequisites when we are talking about indirect restorations? We want the clinician and the technician to work in harmony. How do we get them to work in harmony? When there is ample communication which is happening with the both. So clinician has to supplement the technician and vice versa. So photographs, we need to have an outline form or a sellout form, anything which we want the technician to make a note for, be it a small fracture line, be it some amount of white spots. The tooth looks a little different. There's some amount of translucencies. Again, illusion is not part of this topic today. We want the line angles to be blend this way. We want the tooth to appear in a different way. All of these communications need to go from our side. Then comes our hue chroma value. We need to get the hue chroma value right. What I do in my practice, multiple operators will take the hue chroma value because my eyes might be having a bias. I might tend to look at something. So to have an inter-operator agreement, something if you do a lot of publications, you get to understand, you need to have a standardization to avoid any bias. So you have different operators who will be taking the hue chroma value. Different operators taking at different times to make sure there is no bias. And more importantly, under different lighting conditions, you can use LED lights, you can use your curing lights, you can use your chair lights, you can use daylight. So under different lighting conditions, you need to have hue chroma value, which blends with the natural teeth. Now there's something known as fluorize, which is there. Just like you have polarize, you have fluorize. That also is a great tool, which will give you what you are looking for. Once the hue chroma value is sorted, depending on the thickness of your preparation, you will be deciding what is my outline form going to be. Whether I'm going to be having something which is going to be a monolith, something which is going to have an incisal cutback, something which is going to be layered. So for that, my block shade and my stump shade are of utmost importance. And when we have beautiful restorations coming in, before we have it being luted in the mouth, one last step is to have the shade of your resin cement sorted. That is where your try in paste come in. You will be selecting which is the optimum shade of your resin cement, and then comes your cementation protocols. And trust me, it works. It's worked for me, it is still working for me, and it will work for you too. You can always follow us on Instagram because that's where you get to see what we do in our practice in terms of our clinical expertise. You will get to see what we do on the educational front. When I'm saying we, it's always me and my team. What we do clinically, what we do on the educational fronts, conducting programs, courses, lectures, and of course my hobby of photography and travel. You get to see everything on Instagram. We will have people who are not very tech savvy, who have taken a backseat as far as the social media is concerned. You can always drop in a message. I will reply late if I'm traveling or if I'm busy, but I will surely reply. And my dear friends, I told you earlier as well, we shall see this through and we will meet soon. Thank you all for listening to me, and I hope I made a difference. So when you get back to practice, whenever you get back to practice, remember, value the value. Thank you.